Welcome to Call the Doctor. This is oh, jeepers, the first time I've been back at the show for a couple months now, doing some overseas mission work and some hard work at the hospital. So it's nice to be back. Tonight's guest on Call the Doctor is Dr. Nancy Hancock at the Women's Center. And she's going to tell us everything there is to know about updates with OBGYN, right?
And I have to tell you, there are a lot of people out there smiling right now because when I tell people that I know you, they just say, "Oh, she's my doctor.
Oh,
she's wonderful." So
sweet.
we're really glad you came to town.
Well, thank you.
Oh, yeah. It's interesting, in medical school, that's the one discipline I ran the farthest away from. It's just was so it's nice to partner with somebody who shares my opposite passions. So, well, tell us a little about where you work. It's an interesting thing because the hospital had wonderful management since I came here. It was one of the attractive things to work here, and then as management changed hands, progressive improvements have also been noted. And since 2016, I think the Women's Center opened, right?
Correct.
And that's just a symbol of excellence. One of the many symbols of excellence that is occurring here at Nash. And the Women's Center, I believe, was just recognized as one of the top 15 hospitals that deliver babies in the whole state, from Newsweek, I think, magazine, or maybe it was U.S. News and World Report, and that's an accomplishment, right? Tell us a little bit about the Women's Center.
Sure.
And its role and how it wonderfully serves our community.
So I work for Nash OBGYN, which is a private practice office that is located on the hospital campus. And then we do all of our deliveries as well as gynecologic services at the hospital. The Women's Center is exclusively for pregnant women, particularly those over 20 weeks of pregnancy. Less than 20 weeks, they're typically seen in the emergency room, but any pregnant woman who's over 20 weeks can present to the Women's Center. There's a registration desk there. You don't have to go through the emergency room. And there is a triage area that is to assess women who have a complaint where maybe they're not exactly sure what's going on. And then we have 6 labor and delivery suites, which are exclusive for women who are in labor or who may be having a medical problem that might be a reason for them to need to have their baby. And then we also have a surgical OR that's dedicated exclusively within the Women's Center. Within each of the labor and delivery rooms, there's plenty of space for your family. There's the bassinet for the baby.
Pediatricians come there.
It's actually neonatologists.
Oh, it's even better.
And so the hospital formally employs neonatologists who are available dependent on the circumstances of the delivery. There may be respiratory therapy, there may be special care nursery. We can take babies that are at least 32 weeks and above in our special care. Our special care nursery is quite unique.
32 weeks and above mean it's 44 weeks normally a pregnancy.
40 weeks is pregnancy.
Okay.
If they got to 44, that would
Okay,
be great.
I told you I ran, right, from OB. So 40 weeks is a normal pregnancy, so
40
if they're
weeks is the due
born
date.
34 weeks.
Right, and so as long as the pregnancy is at least 32 weeks along or later, then if the woman needs to deliver, she is able to stay locally here. Our neonatologists feel comfortable taking care of that early gestational age.
And the neonatologist is a specialist in newborns.
Correct. That's somebody who got training in pediatrics, taking care of children, and then did 3 years of additional training exclusively taking care of babies. And the Women's Center upstairs has 16 postpartum suites. And so those are for women who've had their baby. Sometimes they need to come prior to having their baby. Ladies who have hyperemesis or significant nausea and vomiting of pregnancy. Kidney infections can sometimes happen in pregnant women, and that's
So they can
another
stay
reason.
a few days to manage those medical problems.
And then there is also a 10-bed neonatology unit that is quite luxurious in that even though the babies are quite small, the rooms are quite large, and so there is a bed or a couch that turns into a bed, a rocking chair. There's a shower that's for parents' use. They can order meals while their baby's there. And it's the only unit in the hospital that accepts visitors 24 hours a day, 7 days a week.
So in that unit, if a mother's healthy enough to go home but their baby is not, then that mother can stay with that baby outside of the postpartum beds, the after delivery beds,
Correct.
but stay with their sick baby for a prolonged period of time, so the baby doesn't need to be transferred to another
That's right.
hospital.
And sometimes even when moms do have to deliver early, sometimes really early, 23, 24, 25 weeks, once that baby gets to a point where they're called a grower and feeder, meaning we're not doing anything for the baby, but
That's
the
what I
baby's
call
not
my kids all the time.
they're not stable enough to go home. They can be transferred back here so that it's closer for the families. And so we try to work with, when we do transfer a mom at an early gestational age, making sure that our neonatologists here know to be in touch with those folks at either Duke or VITA in Greenville or UNC, so that if a baby's there when they're stable, they might be able to come closer to home.
So largely speaking, you can take care of almost the entire pregnancy population in our community.
Right. It's one where there are, unfortunately, medical problems that can happen at an early point in the pregnancy where a mom would not be appropriate to stay. And the main reason is because of the baby. Taking care of a 23 or a 24-week baby is very different than taking care of a 32 or 33-week baby. And so if mom is stable and the baby is stable as best as we can tell on monitoring, then we do try to transfer those moms while they are still pregnant. It is much better for the baby to be born in a hospital where they are more typically prepared to take care of a very premature
As
baby.
opposed to being born here and
And
emergently transferred.
That's right.
Right.
That's right. And sometimes nature or medical problems have to necessitate delivery. And so sometimes we are able to call a transport team to be here for when that baby is born. Sometimes we have to stay, the neonatologist, not the obstetrician, but the neonatologist would stabilize the baby and then figure out where there's room. Thankfully in North Carolina we have multiple special care nurseries within close proximity. Unfortunately sometimes some of them are full, and so we try to honor the parents' wishes in terms of where would be most convenient for them. At the same time, not only when, particularly if they're still pregnant, we're transferring a mom, there has to be a bed for her. There also has to be a bed for her baby or babies. And so that can sometimes have more of a factor in where mom can go for continued care than their personal
I would think
choice.
so. So certainly Nash's investment into the community and building the Women's Center has added to the quality of even your personal private practice.
Yeah, and it's a really lovely facility. Families like the spaciousness of it. They like being able to have visitors and have their visitors have plenty of room. Within some of the women, the labor and delivery suites, we do have bathtubs. We don't do water births there, but there are a multitude of different interventions for pain control. Only about 50% of our patients get epidurals. Certainly supportive of that. I'm not suggesting that you shouldn't get one, but some people want alternatives, and so we do have quite a multitude of options that are offered, as well as childbirth classes that are taught at the Women's Center and breastfeeding classes as well.
So it sounds like a complete service to the community. That's wonderful. Tell us a little bit about you, where you trained, how you got to us.
Sure. I'll be honest, when I started medical school, the last thing I wanted to do was be an OBGYN. So I understand your apprehension. I'm actually from near Charlotte. I went to undergraduate, or got my initial degree at Clemson University in South Carolina, and then actually have a master's degree in public health from Tulane in New Orleans. And then I actually worked for a little while and then went to medical school at UNC, and then did my OBGYN training in Winston-Salem at Wake Forest, and then did a research fellowship through the OBGYN department at UNC, and then came to Rocky Mount about 7 years ago and have been here since then.
We had similar training prolonged time experience, as we've both been here about the same amount of time.
Oh, okay. I
Yeah.
didn't know when you arrived. Okay.
Well, we're in different parts of the world here.
If
right?
we end up doing something with orthopedics and well, carpal tunnel is something that we see
a
in
lot of
pregnant
pregnant
women.
ladies with
there
carpal
are
tunnel.
A few things.
Yep.
A few things.
And I had a few birth defects that I saw
Mm-hmm.
in the women's center, right? I get called in.
Mm-hmm.
So tell us, before we take a break, about the typical things that you would take care of.
Oh, sure.
Just for general topics, and
Mm-hmm.
then we'll address them in detail when we come back from our first break.
So all of my patients are female, or at least have female genitalia. We do take care of a broad spectrum of issues, everything from cervical cancer screening, birth control, menopausal symptoms, breast exams, well woman exams, which is basically just making sure that you're up to date on your general health as a female.
Like osteoporosis, postmenopausal osteoporosis.
Sure. And then pregnancy, we do talk to patients about preconception counseling if they have medical problems or certain medications they're concerned about the impact of those on pregnancy, sexually transmitted disease prevention, treatment of sexually transmitted diseases.
How about infertility?
It is something that we can talk to patients about initially. I will say that within OBGYN, we do have some specialties that better address some of those issues. Reproductive endocrinology is something where a lot of times patients come to us, we ask a whole bunch of questions and then kind of help figure out what makes the most sense, because it can be related to the man, it can be related to the woman, it can be related just to the frequency of intercourse, or some medical problem that's preventing ovulation. So there's a wide gambit there.
So in summary, if somebody in our community has a challenge to their health care in any aspect of reproductive health or childbirth, they should come to you, and if they need to be channeled to a different direction, you can assist
Sure.
with that.
It
right?
is one where I will advocate that a lot of our primary care physicians in the community do a great job of basic women health services. And so not every woman needs to see an OBGYN just on a regular basis. It kind of depends on what type of doctor that you see as your primary care.
Very
and
true in my field as well.
And what services they offer. And so we do have a pretty high referral population, because I do want to advocate that the primary care providers in our community can do some pretty basic things, and then they know this is kind of beyond what I normally take care of. I think you should probably see a gynecologist, or you're pregnant. We don't take care of pregnancy. We're going to get you to the folks that do.
Right. We've had some primary care people on our show, and we find this community is very talented in taking care of basic problems and even more advanced problems. I have primary care providers who will send me patients that they've injected carpal tunnels for, which is not a common thing, or large joint injections, and that's wonderful that they have that expertise and refer to us for patients who haven't successfully been managed very, very nicely conservatively. So we're going to take a break now, and when we come back, we're going to go into greater details about the topics that Dr. had addressed to us. So we'll return in a few moments.
What the Community Paramedic Program is a program that sends paramedics out into the community to help patients after discharge.
It connects the dots for them. He provides education and also to proactively take care of our patients. So evidence-based practice says that if the community paramedic sees the patient in the home, they're able to decrease the readmission rate. It just decreases the burden on the healthcare system.
Taking chronic patients, it takes a toll on all the providers, from the ED to med-surg, nursing, to the dispatch call takers. Some of the things that we do when we go out to residents is we will do vital signs. We will do medication reconciliation, where we take and look through all their medications. We answer phone calls. If patients have questions, we can help walk them through their needs. We can communicate with their doctors. Sometimes they'll make medication changes right over the phone, and that'll help keep a patient out of the hospital so they can be, at home and healthy. We do lab draws for patients who can't get in and out of the house. We do coronavirus vaccines. We've seen patients who were our high-risk readmitters who had been in and out of the hospital get their diseases under control. Most of the time they get a better understanding of their disease process and they're able to live a healthier life, which is what we want ultimately, is for the patient to be healthier.
Well, after he gets to the routine, he answers all my questions. And he takes the time. I mean, those heart doctors, they whiz in. They're so rushed. And you go, and they're gone. But Till takes the time.
I'm so lucky to have Mr. Till in my life, because if it weren't for him, he would come back and check on me and make sure that that I'm stable and able to go to my doctors and see what kind of meds I need. I won't have nothing.
He's a blessing. He really is.
So being able to connect with patients on a personal level and just talk to them and let them know that it's going to be okay and that you can be healthier, you can resume a good quality of life. I think that helps the community as a whole.
This is where the public would benefit if they had more Tills out there.
Honestly, I would really like to have at least 10 community paramedics to be able to cover our patients.
The more cars you have, the more people you can help, the more lives you'll save.
Welcome back. So in the break, I heard a term I never heard before, and I really need to have
Can you
this
believe
explained
it?
to us. I know, right? So we were talking about midwives and their role, and you had asked a
I said,
question
do you have
about
doulas?
which
Yeah.
I never heard of before,
Huh.
right?
Mm-hmm.
So
I had a
after
good friend locally who was a doula.
Mm-hmm.
yeah. So please explain. What is this doula that she speaks of?
So first, doulas and midwives are very, very different. A midwife in the state of North Carolina is someone who has a bachelor's degree in nursing, typically has practiced as a nurse for some time, and then has gone on to get additional training in managing and taking care of pregnant women, labor and delivery.
Is it a certification
It is.
that they have to
It
get?
is.
Okay.
And so it's through the North Carolina Board of Nursing. And so East Carolina offers a 2-year degree program. There's lots of them nationwide, but it is one where their area of expertise is taking care of pregnant women, managing their labor and delivery. A doula is typically a lay person who has specialized training in being a pregnancy support person. So a doula is someone that you may contact. We do have some in the community here, and they will probably meet with the patient and their significant other 2 or 3 times prior to pregnancy, and it's really getting to know each other. A doula has expertise in helping to come up with different ways to manage labor pain, some different thoughts about how you might want to be positioned, and really gets to know the patient in a way in anticipation of that labor experience. We know that women who are well supported during labor have a better birth experience. They have better birth outcomes. They feel better after delivery. They're more likely to breastfeed. And so there's a lot of advantages to a doula. Currently in North Carolina, they have petitioned with the state to try to make that a formal certification. There are multiple programs, but as of right now, you could say you were a doula. It's something that the patient would want to look into. And then when they arrive at the hospital, they call, or typically en route to the hospital, and say, hey, I think I'm in labor. Or if there's a medical issue where we say, you know what, you really need to stay and have your baby, the doula is typically with the woman at the bedside for her entire labor and delivery experience.
And is this something that your office refers people to assist them getting in contact with a
So
doula?
we do help them kind of identify. There are a lot of part of it is personality. Obviously, if you're going to be spending an extensive period of time with someone and you want that person to be supportive, it's more about getting them to some different resources where they can kind of reach out, because different people meet in different ways in terms of their personalities and what might make the most sense for them during that labor experience. And so part of it is just getting them to a point where here's a way to further look into a variety of different options. They may reach out to that person, speak to several different doulas on the phone before they find this seems like the right one for
Do they have
us.
a potential role in a very, very young person giving birth? Someone who's not as socially mature, a high school level
So,
kid?
good question. It's one where we know that particularly younger patients, it's really important to get them to do the childbirth class. Part of it is learning what to anticipate, and we do have patients, unfortunately, who can be really young, and part of it is helping
Meaning
them.
the mother's really young.
Right,
Yeah.
right. And we try to help them understand their bodies. They may not know what a cervix is. They may not know what a uterus is. They might not even really understand completely how they became pregnant. And so trying to get them to do the childbirth class can be very educational, but anytime there's a support person, and a doula is great, but a family member can also be
Serve that.
as that person. And so doulas have formal training. I don't want to dismiss that. It is really a unique role that they can provide, but in general we just know that patients who have a dedicated support person who's there through the duration tend to have a better experience.
If somebody picks a midwife to help them through the birth experience and something starts going south, something that, different than planned, at what point and how do you get involved? The midwives work for your practice.
They do.
So
And
there's a built-in communication network.
Absolutely.
obviously.
So when a midwife is on call at the hospital, they see patients in the office too, but when a midwife's on call at the hospital, there's always a physician that is readily available for consultation, and that may be something as simple as a phone call. This patient's here for this problem. This is what I think makes the most sense. I agree. Great. Thank you for letting me know. I'm here if you need me. Or it could be a patient who shows up and maybe their water's broken and they have a history of a prior C-section. They're in labor, and so they're sort of thinking, maybe I should try to have a vaginal delivery even though I've had a C-section before. And so the midwife would call and say, hey, this is what's going on, and that would be an opportunity for me to come in and kind of say, here's the risks and here's the benefits or pros and cons of trying to have a vaginal delivery versus a C-section. Or occasionally there are circumstances where everything seems to be going great and then mom starts pushing and the baby just doesn't like pushing, and so they typically stop and call and say, hey, I think this patient can deliver vaginally, but I really think you should be here in case something changes. And so
there's a huge safety envelope because of your effective communication.
Absolutely. And
Right.
so it's one where unfortunately we have unique circumstances where patients present in true emergency situations, and it's nice because when the midwives are on call, they stay at the hospital for their entire shifts. And so I've certainly been called and gone immediately to the operating room and unfortunately introduced myself very briefly right before starting surgery, because the best thing that needs to happen is that baby needs to be born.
Right.
And so they're able to get that ball rolling sometimes more efficiently than might otherwise. So they are a great asset to our community. Midwives reduce C-section rates. The C-section rate at Nash is actually quite low, but we know
And that's a
that
good thing.
It is.
Yeah.
And quite low, it's relative to the national average.
Correct.
Or even the state average.
Correct. It's one where there are most entity or groups, people that, some babies need to be born via C-section. 15 to 20% is about what most organizations would say should be your C-section rate. In the United States, it hovers somewhere between 30 and 35%. Here at Nash, it's around 20 or 21%, and so we're
That's
quite
excellent.
proud of that.
And
Yeah.
why are you proud of it? Why is it better not to have a C-section?
I
like
would say
for
it's
convenience
better
or
to
like-
not to have a C-section. There are certainly indications for C-sections, and unfortunately that sometimes happens. Some babies don't like labor. The placenta is a temporary organ, meaning after you have a baby, regardless of how you have it, the placenta comes out, and sometimes it doesn't work as well towards the end of a pregnancy as it might otherwise, and so babies sometimes just don't like labor. There's some women that their cervix just doesn't dilate, and no matter our best efforts, multiple interventions, if the cervix doesn't completely dilate, you really just can't push a baby out. And then there are some medical problems. Sometimes the placenta is over the cervix itself, and so that would create a life-threatening emergency for mom or for baby if she tried to have a vaginal delivery. And so there are different circumstances under which a C-section really is the right thing. And I know that's really hard to hear. It's one of the things I hate about telling patients that, but at the same time, there are certain things that it's really best for mom and baby, because the real outcome that we want is a healthy mom and a healthy baby.
Right.
And
to have that attitude means you're always prepared for a worst case scenario.
That's right. And nobody wants a C-section, but at the same time, unfortunately, sometimes it is the best option for having a healthy mom and a healthy baby.
You want to go to the other end of the spectrum now, from
Yeah,
baby
sure.
to menopause?
Sure.
Sure.
Menopause.
Yeah.
I bet you get a lot of questions about
I do,
that,
yep.
and we'd love to know what you advise people.
Sure.
You know, how you help them through the journey,
Sure.
what to expect
Sure.
when it happens,
Sure.
when.
First, I would say, what is menopause? The true medical definition of menopause is when you've gone for a whole year, 12 months, with no menstrual cycle. You can start having symptoms of menopause 5 to 8 years before you will actually stop having cycles. And so
And what are those symptoms?
a lot of times patients notice hot flashes, vaginal dryness, increased irritability, anxiety, difficulty sleeping. There's something called menopause brain, which is where your brain is literally getting used to less circulating estrogen, and so it can make you feel like you're a little bit more forgetful. Some patients come in worried that they have Alzheimer's or dementia. It can cause some joint stiffness. It's one where it can also be a reason why people have irregular periods. Sometimes you may have a cycle and may go for 3, 4, 5 months and think, oh, maybe I'm done, and then have another period. And so part of it is unique to each woman in terms of what her specific health problems are, because that's going to influence the conversation, what's going on with her actual cycles. For a patient who comes in and says, I haven't had a period in a year and a half, I'm waking up drenched in sweat, I can't live like this. Part of it is having the conversation to make sure that there aren't any medical problems that make me concerned. And then hormone replacement therapy is something that's a great option. In the early 2000s, there was a big study that came out that made people very, very nervous about hormone replacement therapy.
Regarding cancer?
Regarding a couple different things.
Heart issues too.
Cardiovascular disease, increased risk of heart attack, increased risk of breast cancer,
Blood clots,
increased
perhaps?
risk of blood clots. And so the unfortunate thing about that study was it was a really, really big study. But the women that were in that study didn't start taking hormone replacement therapy until they were in their early 60s. We know that the average age of menopause is around 51. And so you're a very different woman at 51 than you are in your 60s. And so part of it is coming to see us when you start having symptoms, not waiting, and then talking about your own unique concerns. Many women, when they hear hormone replacement therapy does slightly increase your risk of an invasive breast cancer, a heart attack, a stroke, or a blood clot. Those risks are not dramatically higher than they are for
Regular
everybody.
population.
But a lot of patients, depending on their family history, even if they've just had a close personal friend have breast cancer, they hear those risks and say, I'm just going to live with my hot flashes. The good news is there are a lot of other options that are not hormone replacement therapy that can help. Part of it is figuring out what is the most bothersome symptom. For some women, it's just vaginal dryness. They don't feel quite right down there on the regular, independent of sex, and they want to know what their options are for that. For some women, it's really the mood changes. The irritability and anxiety can be debilitating, and so there are other things that we might use for that. Some women may have a personal history of breast cancer, or maybe they had a blood clot during pregnancy, and so those are women where hormones are definitively not recommended, but there's still other options. And so it is one where it's a very focused, unique counseling session with that individual, but in general know that there are many other options beyond hormone replacement therapy that are open and can help with a lot of the menopausal symptoms.
But people, it sounds like they really do need a good counselor, somebody to really talk to. Because I've heard of people who, you know, I've heard you eventually quit having hot flashes. I know people who never quit having.
So it is
ever.
true. It's one where mom's experience with menopause is most predictive, or if you have older sisters, that can help predict what age you might quit having cycles. It could also help predict what your major symptoms may be. A lot of women generationally had hysterectomies, and so they're not really sure when they went through menopause. But it is one where most patients, somewhere between 6 to 24 months. But you're absolutely right. There are some women who are like, I'm going to use my estrogen patch for the rest of my life. And in general, that's an important patient to see me once a year to go over your health history, make sure you haven't started smoking or been diagnosed with diabetes, high cholesterol. Talk about your family history, because sometimes that can be really important. If you have multiple family members who've had heart attacks, hormone replacement therapy might not be ideal for you. And so it is one where there are some women, as you mentioned, who it is okay for them to continue to use hormones really forever.
Without really a significant risk over a general population.
Correct.
So
And it's good for your bone health too, isn't it? I mean,
It is. It's
Very
one
much so.
where I wouldn't recommend
Oh, yeah,
estrogen
you would know that,
just
wouldn't you?
just for bone health, but it can be an added advantage, and it is one where, again, it's just part of the conversation of what are your goals, what is bothering you, what are some other health issues you may have, and how can we potentially deal with those with one thing versus maybe. And over time, I have some patients change, their health changes. And then there are other women who, I've been on hormones for 10 years. Have you ever not taken them? No. And part of that is saying, you know what? Quit. And if 2 or 3 weeks goes by and you feel the same, you probably don't need it anymore. There's not a test that we can do that says, oh, well, if you quit taking hormones, you're going to have terrible hot flashes. It really is to do what we call a drug holiday, meaning taking a break and see what happens. And a lot of women are surprised that they don't have symptoms. And some women, they come back with a vengeance and they're like, I'm never doing that again.
how can you tell? You mentioned menopause around 51 average, but what if somebody says, well, I really don't want to risk having a baby? How can you be sure that they're not fertile anymore?
So as long as you're having spontaneous menstrual cycles, you probably are still ovulating. As women, we are born with a set number of eggs. That's what we have when we start our cycles after puberty. The body does select the best ones first.
It does. That's interesting.
And so we know around age 37, 38 is when it can become more challenging to become pregnant. We know as you get even older, 40, 41, 42, you can still get pregnant on your own. There is a higher risk of having a pregnancy with a chromosomal abnormality, particularly Down syndrome. Spontaneous conceptions, meaning getting pregnant out of the blue on your own, can still happen into the mid to late 40s. And so if you are still having regular periods, I would say it is still a possibility.
Or even maybe irregular periods.
Right. As long
Any
as you're
periods.
having cycles, that typically indicates that you're ovulating. Now, as we age, our ability to actually become pregnant with a pregnancy where you would stay pregnant in your late 40s or early 50s is really low, but it's not impossible.
does that mean the mother would spontaneously lose the baby?
You have a much higher risk of miscarriage as we age and become pregnant, and so it is one where in your mid 40s to late 40s, many women might not even know. They might have irregular bleeding and have a period that they think is, oh, maybe that's a little bit heavier, and don't think anything about it. That doesn't happen very often, but it is something that is entirely possible.
Dr. Hancock, I've known of a number of people who in later life remarried or got married and never had kids and decided they wanted to because they had a younger husband or somebody, and they treat themselves with a lot of hormones and become pregnant.
Oh,
and
sure.
It seems like there's a higher incidence of breast cancer when that happens. Is that true?
It's a good question. As best as we know, the treatment that women undergo for probably what you're talking about is in vitro fertilization. And so trying to get women who may not ovulate on a regular basis to ovulate or be able to collect eggs for in vitro fertilization. They are given a substantial amount of hormones, but it's for a very short amount of time.
Good.
And so there's so many contributing factors to why someone might get breast cancer. Their diet, do they smoke, do they exercise, do they drink alcohol, how much do they drink, family history. And so we don't think that there's a specific relationship between any hormones that you might receive, including birth control hormones or in vitro fertilization hormones, and an increased risk of breast cancer.
Good.
That said, each individual may have some things within their own health situation,
Or family history.
or more importantly, family history, that make us kind of say, there's maybe a reason why this type of birth control might be better for you than some other ones for these reasons, depending on their
Well, and rolling into
health.
that, if there are parents watching with daughters, what do you recommend for, how did they decide to bring the daughter
Sure.
for a checkup for the first
Sure.
time?
So there are a couple different reasons why patients might come in to see me as even a child. Sometimes the pediatrician may say there may be vaginal itching, vaginal discharge. That can happen with overexposure to bubble baths.
Really?
Different contact dermatitis issues. Some small children start to put things in different locations, and so sometimes we do see children. It is one where if periods are preventing an adolescent from learning, in terms of they're worried at school that they may have breakthrough bleeding, they may be having accidents at school, if their cramping is so significant that they can't go to school for a day or two every 28 to 30 days, that's certainly a reason to come in and have a conversation. It is also one if they're considering sexual activity or are already sexually active, to talk about different methods of birth control. Sometimes patients come in to talk about having sex, in terms of they're thinking about doing that. What are some things that they can do to protect themselves from pregnancy, from sexually transmitted diseases? And then we do have patients, particularly around 18 and 19, where they sort of age out of seeing a pediatrician, but might not necessarily need a primary care provider. We fill that gap in terms of just being a general health practitioner for that age group.
Well, you really are providing primary care in that group, for sure.
And it's one where we typically don't start doing pap smears until age 21. And so certainly if somebody said, at what age does someone need to see a gynecologist? Again, it goes back to primary care.
To bring up pap smears and then the younger population, we do a pap smear looking for cervical cancer,
Correct.
right?
Correct.
But part of the counseling that you give to young people is regarding preventing cervical cancer and other cancers later in life with human papillomavirus detection.
So vaccination. So one of
Yes.
the best things that you can do in talking about children and things to think about as a parent, for parents of boys and girls, is getting vaccinated for human papillomavirus. It truly is a cancer vaccination. It helps protect against the 7 most common strains of human papillomavirus that cause cervical cancer. It also helps protect against the 2 most common strains that cause genital warts. Sexual practice patterns have also changed. People are practicing oral sex, anal sex, and so we know that head and neck cancers are actually on the increase from sexual practice patterns, and that comes from HPV. And so getting vaccinated helps protect from a wide variety of things, but we typically
In
think
particular, ugly cancers.
correct.
Right.
And it has to be done prior to someone's having cancer, having sex, right? Or
It's
does it?
best if it's before you have sex. At the same time, it's certainly not wrong. It's actually FDA approved up to age 45.
Really?
And so particularly for women who may be married at a young age and then are not married to that person anymore for whatever reason, that may be something they want to think about doing. Or somebody who has been exposed to HPV, it is one of the ways that we know can help clear the HPV virus is to be vaccinated.
Do you give those injections?
We do. We have that in our office.
What's the youngest age you might consider doing it?
Typically age 11. I think pediatricians and the providers in our community who take care of children start talking to parents somewhere around 9, 10, 11. But if it's done before age 15, they only need 2 shots. If it's 15 and older, then it's a series of 3 shots.
It's been around a long time. It's very safe, isn't it? And to think of being able to have a vaccine so you don't get cancer, I mean, that's I like
There's
that.
only 2, hepatitis B and HPV.
Right. Yeah.
We have a question.
Yes.
Okay.
The viewer said that she had a C-section with
Sure.
her last pregnancy.
Sure.
She wants to have another baby. Her and her husband want to have another baby. She does not want another C-section, so she's apprehensive.
Sure.
So what would
Sure.
you say to
So
that?
a couple of things. One is we want to make sure that the body's had time to heal from previous C-section. And so typically we would recommend waiting at least a year from any delivery, whether that's a vaginal delivery or a C-section, before trying to become pregnant again. It's a lot on the body to support the growth and development of another person. And so taking a break to just let your body heal, rest, recover.
That's true only after C-sections?
No.
Across the board.
Across the board, even
Yep.
vaginal deliveries?
Even vaginal deliveries. It is one where you can continue to nurse, you can continue to breastfeed, you can even become pregnant while you're breastfeeding, and that's not a reason to stop breastfeeding. But in general, waiting a year from a delivery before you try to become pregnant again is ideal. Part of it would be why you had a C-section to begin with, and then part of it would be going into labor on your own. It's one where we know that women who go into labor on their own have a much higher probability of success. Ladies who've had a vaginal delivery before and then maybe had a C-section because their baby was in the wrong position or a breech baby, they also have a higher probability of success. Part of it is counseling about whether what caused the C-section the first time is something that's likely to repeat itself. And so it's hard for me to say specifically, but it's certainly a conversation that can be had, getting a little bit more information. And again, unfortunately, sometimes these are just not avoidable. And it's one where there are certain women where if we let them stay pregnant, they would stay pregnant for forever. And certain bodies just don't want to go into labor. And then part of it is there's kind of 3 parts that we focus on. There's the pelvis, and that's what you're born with. We can't change our hips. That's just how we're shaped. There's the passenger. Babies like to come out with their head tucked like this. Sometimes they're looking straight up. Sometimes their chin is what's trying to come out first. And sometimes we can
Sometimes it's their foot that
That's
comes out
right.
first.
Sometimes
Right.
it's their foot, sometimes it's their butt. And so we can't have too much of an influence on that. And the main thing that we can influence is the power, making sure that you're having strong enough contractions that should cause your cervix to change. And sometimes we can induce people who've had a previous C-section. There are safe ways
And
to
define
do
what
that.
tell our public what you mean by induce.
So most people know that at some point a baby's got to come out. And so many women go into labor on their own, or what we call spontaneous labor, meaning
Like
you
their
start,
water breaks and then it
they start having
progresses
regular
and
contractions where they're like, this is annoying, and then it increases in intensity and frequency. You're like, okay, something's
like
not
it's going
right.
to be.
That's right. And then sometimes their water breaks. Sometimes they come to the hospital for other reasons. We check your blood pressure at every prenatal visit. Occasionally, patients can be diagnosed with high blood pressure just because they're pregnant. There's something called preeclampsia that is a disease only of pregnant women, where they may have headaches, vision changes, typically have elevated blood pressure. Blood pressure may be so elevated that we say, you know what? The cure for preeclampsia is delivery, and so we need to induce you. And what that means is that we give you medicine to make your body go into labor. A lot of the early labor that you would have at home that you might not even notice happens in the hospital. And so there are a variety of different methods that we can induce somebody for, and there are a variety of different reasons that we might recommend that. We also know that the ideal time for a baby to be born is somewhere between 39 and 40 weeks. So kind of from the week before your due date. Many women nowadays have other children, they have other responsibilities. Childcare can sometimes be an issue, and so a few years ago there was a national study that was done looking at, is it okay to induce somebody after 39 weeks, Or should we just let them stay pregnant up to a week or two after their due date? How do babies do? How do moms do? And we now know that there is not an increased risk of C-section from being induced somewhere between 39 and 40 weeks. A lot of the labor that you would have at home is going to happen in the hospital, but for some families and some women, frankly, they just get tired of being pregnant. It can be a lot on the body. It's really hot in North Carolina in August, July, June, and so it's one where sometimes people just choose to be induced after counseling by their provider as to whether that makes sense or not.
We have another question.
Sure.
This young lady's in her 30s, and she's heard that you need to be tested for cervical cancer every year, and then she's heard every 3 years.
Yep.
So what do you recommend?
Yep. So it's not what I recommend. Believe it or not, there's a group of people called the American Society for Colposcopists and Cervical Pathologists. And so that's a group of people that all they care about is the cervix. And that's all they think about, and that's all they talk about. And they get together as a group every 5 to 7 years and issue international guidelines. And so it's one where it's not what Dr. Hancock thinks is the right thing to do, it's what the ASCCP thinks. And so between ages 21 to 30, typically it's a pap smear once every 3 years. Once you turn 30, we're going to do a pap smear, but also HPV testing, or testing for human papillomavirus. There are several strains that are significantly associated with cervical cancer. If you test negative for HPV and your pap smear is normal, then you only need one once every 5 years. That doesn't mean you shouldn't come in on a regular basis. We do still look at your cervix to make sure it looks normal. We talk with you about a variety of different things in terms of birth control, breast cancer screening, bladder function, sex, discharge, a variety of different issues, but it is one where you don't need a pap smear every year anymore, and that's a huge shift. I get asked that a lot, and it can be upsetting for certain patients. We're never going to refuse to do a pap smear, but at the same time, it's important to know that medically you don't necessarily need one every year.
How do you tell people to protect themselves from getting sexually transmitted diseases?
So condoms are the best way, to be perfectly honest. It's one where chlamydia is very, very common, unfortunately, in our adolescent population. I probably diagnose 2 or 3 people with chlamydia every single week. Unfortunately, as women, we tend not to have symptoms, and so if you have a new sexual partner, one of the best ways is to both, particularly if either person has had sex with somebody else before, go get tested.
Test.
It's a great way to invest in yourself and invest in your relationship and say, you know what, I think we're going to take this to the next level. I think that's great. Let's go get tested to make sure that we're both negative.
Where do you get tested?
So you can get tested at the health department. You can get tested with your primary care provider. You can get tested in our office. There are a variety of different options for that. There are a variety of different things to be tested for. Gonorrhea, chlamydia, and trichomonas are tested for with a vaginal swab. And then it's also possible through sexual contact to become infected with HIV, syphilis, hepatitis B, and hepatitis C. And those are screened for by laboratory draws. I tell patients condoms are the best way to protect yourself. Unfortunately, condoms are not great to help prevent HPV infection or herpes infection. Genital warts is caused by human papillomavirus, but not the same types that cause cervical cancer. And so cosmetically, or the way that things look, genital warts can be very upsetting, but for your overall health, in general, they're not a big deal. Same thing with herpes. Herpes is a virus. Unfortunately, it is very easily transmitted even if your partner doesn't have any active lesions. Oral herpes can be transmitted with oral to genital contact, or meaning oral sex. Genital to genital contact is how herpes type 2 can be transmitted. And so unfortunately, even skin to skin contact can sometimes transmit genital warts and herpes. But condoms, frequent testing when you change partners. That's the other thing I tell patients is anytime you have a new sexual partner, it's a good idea to get tested so that you know where you are in your journey.
A major point being that STDs, or sexually transmitted diseases, may not be symptomatic.
Correct, particularly in women. Unfortunately, we kind of have the Centers for Disease Control and Prevention, or the CDC, recommends that patients between 15 and 24 be screened for gonorrhea and chlamydia every year when they come, and it is really surprising the number of patients who either sometimes don't tell us that they're sexually active, even though we ask, or just maybe embarrassed or ashamed, and then come back as testing positive for chlamydia or gonorrhea, which are bacterial infections. They are easily treated. Chlamydia in particular can have an impact on your fertility. A lot of times patients think, oh, herpes is terrible because it never goes away. For your overall health, it's not a big deal. Chlamydia, on the other hand, while it will go away, can really impact your fallopian tubes. It can create scar tissue on the inside that can then, in the future, interfere with your ability to become pregnant.
I've heard people as they've gotten, more older than younger, start talking about they bleed, and they just bleed, and they can't control it. What's going on when people say that?
So there are a wide variety of things that can happen. It's one where there could be something anatomic, meaning something in the uterus itself that's causing bleeding. That can be anything from cervical cancer. It could be a growth inside the uterus, like a polyp or a fibroid. Fibroids are incredibly common, particularly as we age. If you ultrasounded 100 women in their 40s, 80 to 90% of them would have at least one fibroid.
Wow.
It kind of depends on where the fibroid is located as to whether it will cause symptoms. Again, based on age, teenagers can have irregular periods because they're not ovulating on a regular basis. That is very common in the first year or two after you start having periods. Later in life, you may also not be ovulating on a regular basis, but that's because you're approaching menopause. It's possible that you could have a precancer or cancer inside the uterus itself. It's also one where there could be a medical problem going on. Women who have thyroid problems can sometimes come see me, and their main problem is that their bleeding pattern is irregular, or they're having heavy, long cycles. Get their thyroid hormone level under control, the bleeding fixes itself. And so there are a wide variety of reasons that may happen. A lot of them are age dependent. And so when they come in, a lot of times we do tend to check their blood count to make sure that they're not anemic or have a low blood count because of the bleeding. And then it really depends on their age and kind of what else is going on. A lot of times an ultrasound is a great way to get a good view of the uterus. Problems with the ovaries typically do not cause changes to your bleeding pattern. A lot of women become concerned about ovarian cancer, which is devastating but not common, and they see me because their bleeding pattern is unusual and they're worried it's from cancer of the ovaries, and that's not common. It could be cancer of the uterus, but ovarian cancer tends not to have any bleeding symptoms.
Let's backtrack a little bit, if you can, on cancer of the uterus and cervix. When does a woman who thinks she's in menopause stop getting pap smears?
So typically age 65. It's one where there are certain circumstances where we might continue to do that if they had an abnormal pap smear or procedure to their cervix earlier in life because of cervical precancer, or certainly if they have a personal history of cervical cancer. They may not have a cervix anymore, but we still do a pap smear of the vagina, because they can get vaginal and vulvar cancer. But in general, unless you've had a specific treatment for cervical precancer, age 65. There isn't a screening for uterine cancer. And so that tends to be more common in women who are postmenopausal or who have stopped having periods. And the symptom that they typically present with is bleeding. Patient comes and says, I haven't had a period in 5 years. I went to the bathroom the other day and wiped and saw some blood. And it may literally only be that small amount. I have some patients who come for a regular well woman exam, and we ask, any bleeding? Well, over the last few months I've had a couple times where I've wiped and seen blood. And so that definitely needs to get checked out to make sure that it's not cancer of the uterus. And so that's something that certainly if you haven't had bleeding in more than a year and start to have bleeding, that's a reason to call your primary care provider or contact us, because that's not normal.
When do you stop doing pelvic exams, though?
Good question.
Because that's not the same as a pap smear.
Correct. So
Right.
a pap smear truly is a collection of cells from the surface of the cervix, and that is a screening for cervical cancer. A pelvic exam is where I insert 1 or 2 fingers inside the vagina and then feel the uterus. The purpose of that is to make sure the uterus is not enlarged, to make sure it doesn't feel fixed, and also feel out on either side to make
Can
sure
you
that
feel
the
masses, like
you
fibroids?
can.
And
You can feel if the uterus is enlarged. You may be able to feel cyst. You may be able to tell something's not normal. I may not be able to tell you exactly what's going on. Sometimes when I do that exam, patients have pain and they're like, ow, that hurts. A lot of times if the pelvic exam is not normal, then we do an ultrasound to get more information. Medicare will pay for a patient to come to see me every other year. And that is something that, unless there's something specific in their...
Is that for a well person exam, or what if they have a problem? Will they?
That's different.
Okay.
If you have a problem, you should call us. But
Right.
if you are in otherwise good health and are not having any female-related issues, it is very reasonable to come every other year. And that's to have a breast exam and a pelvic exam. It is one where I still have some patients who do want to have pap smears. Again, we're never going to refuse, but at the same time, it's a conversation to figure out why they so passionately want to have a pap smear, to help maybe answer some questions about anxiety or fear, or maybe they have a friend who had cervical cancer late in life.
Or a sister or a mother.
Exactly.
Right.
Exactly. Cervical cancer tends not to be hereditary. Uterine cancer also tends not to be hereditary. Ovarian cancer is a different conversation, and uterine cancer can be, but typically is not. But cervical is not hereditary, so that's an important point for people to know.
There's a genetic link between uterine cervical cancer and breast cancer, is there not?
So there can be a genetic link between breast cancer and ovarian cancer.
Right.
There is a separate condition called Lynch syndrome, which can be a link between breast, uterine, pancreatic, prostate, and lung cancer. And so that is a unique circumstance where you would have someone who has multiple family members, typically for multiple generations, that have different types of cancer, not necessarily all the same. But breast cancer is typically not associated with cervical or uterine cancer.
And then mammograms. How often should you do it? Assuming it's normal.
Sure.
Obviously, that changes if you detect something.
Sure.
And at what age do you have to stop doing them?
And when do you start?
Sure.
Oh, very good point. Yeah.
So mammograms are quite controversial, to be perfectly honest. If you asked most OBGYN doctors, they would say typically at age 40 and every year thereafter.
Starting at age 40.
Starting at age 40.
And every year?
Every year, as long as you have 10 years of healthy life left, or if you would do something about breast cancer, if you were to be diagnosed, you should continue to get mammograms. If you're diagnosed with something where you wouldn't undergo treatment for breast cancer even if you found out that you had it, or you have other health problems that are more likely to kill you before a breast cancer might, then that's when you should stop. If you ask the American Cancer Society...
Well, that's kind of super vague, isn't it?
It
It's a
is.
confusing foundation to provide counseling.
Yeah, and it's one where American Cancer Society typically says starting at age 50 and then every other year. And there's lots of advice in between. Part of it is personal concern. Medical anxiety is very real. At the same time, I have some patients who say, yeah, I know, I'm going to do this, every other year, every 3 years. And so it is a conversation. But in general, most recommendations would say starting at age 40 and every year thereafter.
And we are out of time. We've got to have her come back.
Absolutely.
I've got more questions right here.
I have 50 more.
You want to do your normal spiel at the end?
Well, we're not going to talk about COVID anymore. But
Well,
I do...
You wrote the hospital, though,
Oh,
right?
yeah, for sure. this is a typical example of excellence that's in our community. You don't have to travel out of our community to experience the wonderful health care that the Nash community offers, both with employed physicians at Nash, all of which are stellar. We didn't talk about your anesthesia services, which I think we overlap, the same ones that I use.
She's coming back, right?
Yeah, she has
Please.
totally amazing anesthesia services. And we're both in private practice, and so whether we're in private practice or employed by the hospital, the complete group at Nash serves us and the community just wonderfully. So thanks to Dr. And thanks to Jean again, and we'll see you in a week or two.
Thank you.
Good night. Thank you.